Now doctor, have you heard of disseminated intravascular coagulation? In pathology we studied now, in Robbins pathology or Shambulingam pathology, whatever. In that what did we study? What is disseminated intravascular coagulation? Gram-negative sepsis will release a lipopolysaccharide on the membrane of the gram-negative bacillus, which stimulates the clotting cascade, coagulation cascade to explode, and all clotting factors will get activated and they get consumed. And they will form the fibrin thrombi in which platelets also get sequestered. So what do you come across there? All clotting factors get consumed and platelets also will diminish, and you get a thrombocytopenia even in the case of the DIC. Whereas in this case, are the clotting factors consumed? No. How will be PT-APTT? Normal. It won't be prolonged. But the patient will have low platelet count. Why is this important? What sir, DIC and TTP कहाँ है, DIC कहाँ है, दोनों के बीच में रिश्ता क्या है? Why so many factors we are worried about? Definitely we are worried about. How will a patient of TTP or HUS will be presenting? TTP or HUS is a patient who is febrile, who recently, if you take HUS patient, hemolytic uremic syndrome patient or a TTP patient, recently has a history of diarrhea and dysentery. After 2 to 3 days after having a GI tract infection, he develops uremia, thrombocytopenia, fever, altered sensorium, and you discover that he is suffering from TTP or HUS. He is a febrile patient. Even a DIC patient also had sepsis and he is also a febrile patient. So what we are handling here, thrombocytopenia in a febrile patient. It can be due to DIC or it can even be because of TTP and HUS. What is the single important laboratory parameter which differentiates between the two? PT-APTT is prolonged in the case of the DIC due to the consumption of the coagulation factors, but the PT-APTT is normal with a low platelet count in the case of TTP, HUS. That's what you need to fundamentally understand. This is the only thing they will test you, doctor, in the tomorrow's exam. Tomorrow's exam or life's exam. Did you understand this point or not? PT-APTT normal in TTP HUS because there is no consumption of coagulation factors. It is prolonged. The remaining thing is very easy. Okay. So next time when you open the book and read microangiopathic hemolytic anemia, every time first thing as a parrot, what will you remember? PT-APTT matter only. So every topic has 2 to 3 crucial points. पूरा रामायण पढ़ने के बाद राम को सीता क्या होगा अगर समझ नहीं पाए तो there is no fun in reading, and the job of the teacher is only to make you understand राम को सीता क्या होगा. Mother, auntie, wife, daughter, daughter-in-law. After all, entrance is what? Entrance MCQ means what, doctor? Multiple choice question means. राम को सीता क्या होगा? A, B, C, D, all of the above. What will she become? If you read the concepts, if you are analytically clear, even tomorrow in the hospital also, you get a patient who is comatose. If you have differential diagnosis in the mind, you will have for everything 2 to 3 clue points. Let me think that this comatose patient is a case of encephalitis. Why are you thinking like that? Because of the fever, because of the nuchal rigidity, because of X1, 1, 2, 3, 4 points. I think that it is a case of the hemorrhage in the brain because of the asymmetric pupils. Like that, even clinical diagnosis also you have 1 to 2 clues as a clinician which you need to have in hand, and you need to basically parade those important evidences. Now coming to the clinical features. There is a hemolytic anemia due to the thromboangiopathy, microangiopathy. Thrombocytopenia will be there, renal failure, fever and fluctuating transient neurological signs. What is this called as, doctor? Reynolds pentad of microangiopathic thrombocytopenic purpura. Okay, some of our classmates will be experts in some topics. They will ask favorite questions. What is Reynolds pentad? What is tetrad, etc. Okay. Now the question is, why renal failure? Because this microangiopathic phenomena is involving the renal vasculature, decreasing renal blood flow. If there are no neurological deficits, only renal failure if it is there, what do you call it as? HUS. Along with that, if focal neurological deficits also are there, you call it as TTP. Why TTP will cause focal neurological deficits? Same logic. The microangiopathic process and microthrombi are forming in the circulation going to the brain. Then you get TTP. Summarize, doctor, what do you have? Anemia due to hemolysis. You have weakness and fatigue and confusion, which is fundamentally neurological. Then there is a fever which is a low grade fever once more. It cannot be high grade fever. Then you have a renal failure and bleeding because of thrombocytopenia. The combination is what you basically come across. So summarize, doctor, ITP versus TTP versus DIC. What are the fundamental differences? TTP is endothelial defect, Adamstat. Then thrombin excess consuming the coagulation factors is DIC, and antiplatelet antibodies in ITP. If you look at the patient, TTP, DIC are very sick patients, emergency, you have to run. ITP relatively petechiae are there, which are itchy. That's the only problem that he is having as on now. Then cystocytes are a classical feature of TTP, but cystocytes may also be there in DIC. So that is the reason it is good, unique feature, not very unique for TTP alone, even DIC can cause, it can't differentiate. Therapy in case of TTP is what, doctor? Plasma exchange. By doing plasma exchange, what will you do? You will clean the floor. All the microthrombi in the plasma are washed out by passing the plasma through the dialysis machine and once more bringing back the plasma which is pure without thrombi back into the patient's body. That is the treatment of plasma exchange. And we also give vincristine in the management of TTP, whereas DIC you need to treat the underlying sepsis and you need to give fresh frozen plasma to replenish the clotting factors. And in ITP you can give steroids, IVIG or splenectomy is considered to be the management of choice is what need to be remembered. So what you need to do? Plasmapheresis. Patient's plasma is taken, passed through the machine and once more recirculated back into the patient. And doctor, it is not an easy job. You have a pediatric patient, recently had the history of profuse dysentery diarrhea. Post dysentery diarrhea after 2 to 3 days he developed this Adamstat deficiency has come out and the patient is having profuse microthrombi, and because of the diarrheal episode earlier he is severely hypovolemic. In him taking out plasma exchange and doing is a challenge, but not impossible, but a challenge. But response is very good. A patient who you feel almost dying will wake up and once more go back to school and get the top rank in the class. I still remember Ravi was our patient, very cute boy. He was in 3rd class. Mother brought in state of a severe acute renal failure. Severe acute renal failure, and he was having severe anemia with a very low platelet count. When we were doing plasma exchange, that catheter has undergone thrombus and embolized also. So we need to heparinize. Due to heparinization, he was bleeding. It was a big mess. But doctor, any patient, even if got messed up, if you raise your sleeves, sit on the side of patient and wake and awake like a hawk and take care of the patient and sail the tempest of the night, patients won't die that easily unless you let them die. Especially pediatric patients, they'll have a wonderful recovery. What you thought is lost today is the tomorrow's nation's top citizen if you make him survive that night. So that is very important. We can give steroids, we can do splenectomy. Platelet transfusions should not be given, contraindicated. Why? If you give platelet transfusions in a patient who has got TTP, they all go and sit inside the microthrombi. There is a further occlusion of the vessels and there is a worsening of the renal failure, everything. So platelet count, platelet transfusion is contraindicated in TTP, indicated in the case of the ITP, even in the case of the DIC. Hence you need to know how to differentiate between the three. That's very, very important. That's all the story, doctor. What are you going to write tomorrow for the exam? Adam, stat 13 is a buzzword. Reynolds pentod, you are not going to forget. Then cystocytes is the third word. Normal PT-ABDD is the fourth buzzword. If they are visible in your answer sheet, examiner Kush Hua Mugambo, he will give you full marks. That means you understood the concepts. Now doctor, Bernard-Solier, Glangeman's thrombasthenia, what is the difference between them from von Willebrand's? We are now going to talk about the functional platelet disorders. Bernard-Solier, it is an autosomal recessive disorder. To understand these three, first you should understand very basic facts. See doctor, this is the vessel subendothelium. Then there are receptors on the platelet called GP1B receptor. It binds with the von Willebrand factor and makes platelet to adhere to the subendothelium. Then one platelet दूसरे platelet को fibrinogen के साथ there will be adherence, and for that you require GP2B3A as a receptor. Glangeman's is the deficiency of this GP2B3A, and Bernard-Solier is the deficiency of the GP1B, and the von Willebrand is the deficiency of the von Willebrand factor. If you know this, you know everything. Now doctor, fundamentally Bernard-Solier is the problem of platelet adhesion to the subendothelium, and if you look at the peripheral smear, you find abnormally large platelets, and the platelet count will not be very low, mildly it will be low. But fundamentally it is a functional platelet disorder. Ideally it is expected to show normal platelet count with a bleeding diathesis, dysfunctionality. But still platelet count will be mildly low, not severely low.